Thanks very much, Rob, and good morning. So, I remember the first time I really felt like a resuscitationist. It was an evening shift 20 years ago. I was a first-year registrar, and the buzzer went off and it said Medivac. And back in those days, that meant there'd been some terrible accident pre-hospital, and we had to go out from the ED to help. Now, I'd never been to a roadside before. I'd had no training for pre-hospital care, but I found myself in the back of a police car, speeding to the scene with one of our nurses. We got there, and it was mayhem. There was twisted, mangled wreckage, there was a patient in the middle, and there was paramedics and firemen and police officers. And of course, I jumped out of the police car and I ran over to where the patient was. And I have this vivid, visceral memory of my boots slipping on a combination of blood and broken glass and oil. Of course, I elbowed my way past the paramedics into where the patient was. We intubated them, we took them back to the hospital. I don't remember much of what happened to the patient, but I certainly remember that feeling of exhilaration and excitement and achievement. And that lasted for some days. I told the story to the people back in the ED to nods of approval. I could just feel like they were treating me differently. If I'd known who John Hines was, I would have thought I was well on the way to being like him. So you can imagine I was pretty pleased when one of the consultants came up to me and said, we're going to start some pre-hospital training sessions, Vic, and we thought you might like to come along. Yep, I thought, in the club now. So I got there, it was a Wednesday, again I remember it vividly, and there were about 30 people in the room. And the opening speaker was one of the senior paramedics. And his opening words haunt me now. So we decided to start these sessions after a roadside a couple of weeks ago where a lot of stuff went wrong and it became obvious that the ED registrars didn't know what they were doing. That was my case. Apparently I wasn't a resuscitationist. I didn't know what I'd done wrong, and of course I was too ashamed to ask. But I knew I had to try harder. Now, we're going to leave my story there for a minute because I'm guessing I'm not the only person in the room that's had a reality check at work. So I'd like you all to think back to a time where one way or another you were somewhat deluded about your performance. Now, because there is some bonding in shared vulnerability, I thought we might use this as a chance to get to know each other a little better. So I've got a task for you. I'd like you to turn to the person next to you, say who you are, where you're from, and maybe share the 30-second version of that reality check. So I'm going to give you a minute, we're going to have the lights up, and we'll come back in a minute's time. Okay, we might start coming back to the middle now. I'm sure those conversations are to be continued. Now, my apologies for any PTSD that might have caused. But look, we shouldn't feel bad. Lack of insight is nothing new. In fact, on a scale of 1 to 10, you probably think you're a 7, and you wouldn't be alone. In fact, Simon Carley talked about this at SMAC last year, the Dunning-Kruger Effect, where it is a natural thing for us to think we're somewhat better than we are. So these Nobel Prize-winning psychologists looked at this across a number of different domains of performance, and what they found is that particularly the poor performers, those people at the bottom end of that green line, dramatically overestimate their performance as shown by that red line, across a range of different things. And as Simon also explained, this is why somewhere between 60 to 80% of people think they are better than average drivers. So, we've got on one side this Dunning-Kruger effect of thinking we're better than we are. But of course, we have this very real imposter syndrome, where the objective evidence is of good performance, but in fact the reality, or the perception is that people think they're no good, and that's common too. So these might seem at opposite ends of a spectrum, and to some extent they are, but what they share is a big gap between these perceived performances and the true performance. Now, as resuscitationists and in other worlds, of course, this gets in the way of improving. So what's the answer to this? And I would suggest that, like many things in medicine, it's a combination of art and science. And let's start with science. What would science say about how to improve and how to close that gap in resuscitation? And let's start with the most basic, chest compressions. As we know, rate and depth of compressions are critical. Poor quality CPR is a preventable harm, according to the American Heart Association. And it's easy, right? Push hard and fast. We thought so too. And at the Gold Coast University Hospital, we were pretty sure we had a good BLS system. We'd send people off for their assessments by the nurse educators. Pretty much everybody passed, and we thought we were doing good BLS. For a variety of reasons, we've moved to a different system where we have these mobile carts that come to people, and they have a very much abbreviated but machine-based assessment. And so just to give you an example of what this looks like, this is Eliane, our simulation fellow, doing some excellent CPR, as she can see in real-time feedback on that screen. So what she sees in real time is something like this, and her good chest compressions are green. They're the right depth with the right recoil, but the yellow ones aren't quite deep enough. And so she can dramatically and very quickly improve to the appropriate performance because of this feedback. That machine is not subject to the same cognitive biases as we humans. Now, not only were we able to improve our individuals very quickly, but we thought we were pretty good as an institution. Maybe not, because that machine feeds back into our version of big data, and apologies to the Gold Coast ED people in the room, but as you can see, we were good, but actually not perfect. And so this allowed us to have a snapshot across the whole institution to look at how we should direct our performance improvement. These were actually first attempts. Almost everybody was nearly 100% on their second attempt with the feedback. So that's basic life support. Let's step it up a little bit. Let's think about airway management. We all go to courses. How many people were at the airway course yesterday? We want to improve for good reasons. But do we really know where our individual strengths and weaknesses lie? So my first example of this, I just want to talk about situational awareness and airway management. This is hot off the press, Emergency Medicine Australasia this month. It was a study done in a New York trauma centre, 100 consecutive intubations on real people. And the methodology was pretty simple. They just, in a standardised way, timed how long did the intubation take with their iPhones. And then they said to the providers, how long do you think it took to intubate the patient? Now, the providers thought that their average time was about 23 seconds. The reality was nearly twice that long. Similarly, when they said, did your patient desaturate during the period you were attempting to intubate them? They only recognised that about half the time. These aren't narcissistic, insightless people. These are people like you and me having the Dunning-Kruger Effect on show. The other thing that we've looked at is how can we visually capture whether people have this issue with situational awareness. These are pivot head glasses. They've got a little camera between the eyes and a little microphone. And my thanks in advance to Warwick Isaacson, who is one of our registrars, who agreed to not just wear these glasses during a simulation, but also show the video. He's going to do an intubation using a CMAC, a video laryngoscope. And of course, we teach, just look with direct view. Of course, if you have to look at the screen, keep looking at the screen. And he's pretty sure that's what he did. And we'll just have a little bit of sound with that, thanks.
Just give it a bit longer, guys. All right. Okay, so the bougie is in with direct view, so...
Our human brains see what we want to see. We don't necessarily realise that we're looking here and then here 10 times. So I think there is advantages of us using science and technology to help close that gap between what we perceive we do and what we really do, and to guide our improvement. But let's go back, it's all about me, to my story back in the roadside 20 years ago. There wasn't then, and I don't think there is now, a simple technology solution to assess my performance. The missing link here was a feedback conversation. A combination of naivety and shame prevented me from getting the information I needed, and my consultant just didn't know how to tell me. Now, of course, this is a tragedy, but also an opportunity, because this is the art of performance improvement through feedback conversations. Because one of the things Dunning did find was that although we're not so good at assessing ourselves, we're pretty good at assessing other people. So to a large extent, the road to self-insight, the road to knowing how good we really are, lies through other people and lies through that feedback conversation. Now, giving feedback is hard. I did a little Google search, how to give better feedback, found 293 million hits on Google, and we've got about 7 minutes, so I'll condense it for you. And I've got just 3 thoughts. The first is, be honest. The second thought is, do it often. And the third is that we need to be experts at extracting feedback, because the people giving it to us aren't going to be very good. So let's think about each of those. So the first of these, be honest. Now, that sounds simple, but we have to really question this assumption we all have inside that we can't be direct and nice. We can, and it shows respect, but it takes practice. Which brings us to the next one, which is do it often. Now, we might have variable opportunities to provide feedback, but I'm guessing we should start the habit here at SMAC. There's about 100 speakers over the next 3 days. They're all suffering from Dunning-Kruger Effect or Imposter Syndrome. They've got no idea how good their talks are. But they all want to improve, so we can help them. So we're going to practice this giving feedback in these 2 simple steps. The first is we're going to get rid of, great talk, mate, not enough. We're going to go, number 1, I liked your talk because your slides were clear and simple. But then we're going to woman up and take the next step. The one thing I thought could have improved your talk was maybe stand more still, don't walk around the stage, whatever it is. Now, if you're still a little shy to do that face-to-face with those 100 speakers, you will notice in your feedback on the website, in fact, there's 2 boxes just like that. The things I liked and why, and the 1 suggestion for improvement. So there's a chance to get into the habit. All right, but what about this last bit? How to extract feedback. And again, it comes back to me. You see, I never had that feedback conversation that I deserved 20 years ago. So I was rather hoping you could help me have it now. So we're going to have a little role play here, and Dr. Brazel, consultant Dr. Brazel, is going to give some feedback to Registrar Vic, the 27-year-old that's just been at the roadside. And of course, consultant Brazel is going to need a little bit of help from you. So I'd like you all to get out your phones or whatever device you're using. Open up Twitter. And if you need help with this, go to the Genius Bar at morning tea. And I want you to provide your top tip to Dr. Brazel using the SmackDub hashtag. Give her a top tip on the feedback to give to poor Registrar Vic. So I'm going to give you 30 seconds to do that, and then I'm going to hear from Andy your top suggestions. Off you go. 30 seconds. All right, Andy, have we got some early suggestions?
Lots of early suggestions and abuse about the Wi-Fi, but if Dr. Brazel could fix the Wi-Fi, it's obviously within your skill set. You could do that, first of all. So not a huge amount, but maybe worth someone in the front rows would like to shout out a suggestion.
Oh, old school. What, you're going to leave her on her own? We can do that too.
Aim to help her reflect.
Aim to help her reflect. Okay. All right, that sounds like a good one. Any others?
Got it now.
Be honest but kind. Okay, all right, that's pretty good. Any final ones?
We have a few coming through on Twitter now here, so there's some useful ones. There are some suggestions not to use elbows.
Not
Sounds
use
a little
elbows.
bit rough.
Okay, got it.
One top tips people often talk about is be clear and concise and
Okay.
avoid the shit sandwich, as people have been described.
Avoid the shit sandwich. And I learned what that was in Danish yesterday. Lørdag sandwich. Yeah, thank you, Sandra. All right, well, let's give it a go. Okay, so we're going to have Dr. Brazel here giving the feedback to Registrar Vic. So just so you've got that picture, 47-year-old Dr. Brazel, 27-year-old Registrar Vic. I know what you're thinking. She doesn't look a day older. It's a tribute to my skincare routine. So, thanks very much for having this time, Vic. Pretty big step up going on a roadside. And I thought we should just do a little feedback session. And, how do you think it went? Yeah, good. It was pretty exciting. And getting that tube in, that was good. I am a bit worried, though. I've never done one of these feedback things with you, that something kind of went wrong. No, nothing, really wrong. It's a big step up going on a roadside. There's a whole bunch of systems there, and, you've got to learn about those. And when you do more, you'll improve, you'll find that. But yeah, no, it's hard. Nothing really wrong. Oh. That bad. You sure? Yeah, like I said, it was pretty good, especially for a first-year registrar. Look, can I just ask, two questions? You said that some stuff was good. Can you tell me what was good and why? Oh, sure. As you said, the tube was good. That was under pressure, time pressure, an unfamiliar environment. And I know you spent a lot of time in the sim lab, Vic, and I think it's paid off. Oh, no, that's good. That's good to know. But, was there anything that anyone thought I could do to improve? Oh, well, since you ask, the paramedics were a bit worried about scene safety, and they said that you just ignored the scene controller. And look, I would be worried that could lead to some safety issues for you and the rest of the team. There's a scene controller? Yes, there is. I thought it would just be a knowledge gap. I didn't think you would have deliberately ignored them. Yes, there's a whole system of who's in charge. It's often one of the senior paramedics, and they kind of direct things there. But look, that's a knowledge gap. We can work on that, and then we should really set you up a lot better to improve. Oh, great. So, then I'll improve, and then I'll be like John Hines. Oh, you'll improve. But you'll never be like John Hines. So, ladies and gentlemen, smack dub, you are resuscitationists. But with a combination of some art and some science and getting that feedback will be even better. Thank you and have a fantastic smack.
Vic, what a brilliant start to Smack Dub. Thanks very much. Okay, over to Andy.
One of the ones kind of coming through to ask really is, do our examinations cover any of this? So
Good question.
how can we structure this in?
The insight gap or the giving feedback bit?
Even both, if you could.
Yeah,
but-
so I think it is an observable skill, giving feedback, so I think it is accessible as a result. Although there is an art to it, there are good principles that I think you can see if are present or absent. In terms of the perception to reality gap, I think the more that we can show people reality, it helps them to recognise they need to be looking for a gap. So I think there is a meta level to this as well.
Okay. And a little bit of this then, is this just all about having more supervision? I know from the Irish context, maybe we don't have quite so many consultants as the rest. Can we just fix this with more staff?
Not necessarily, because although I described this feedback episode as between a consultant and a registrar, obviously I think for most of us, for most of our career, the key is to get peer feedback. It's actually easier when you're a trainee, I think, because there is a structure there, whereas I think when we are consultants, attendings, whatever your terminology is, it's harder for us to do because there are barriers to do with our self-esteem, but I think it's more important than ever that we get that self-reality road through others who are our peers. So not necessarily. I think it's about asking people around you.
So one more just comes through on Twitter from David Tragan, asking, how do you feedback well to trainees if you don't feel particularly expert yourself doing it?
Yeah, no, I think that's a good, that's a cultural thing, and I think often we feel like we need to have a better knowledge or skill to be able to give feedback. I think really we should think of ourselves more as just a mirror and really say, this is what I saw, this is what I thought, but let's talk about what happened and how you perceive it, and I think then it can be just as useful to get feedback from people who are not as so-called expert as you are.
Super, Vic. Thanks very much.
Thank you, Rob.